So we are going to go ahead and get started with this next session. This session is called Youth Policing and Mental Health Partners in Care. And so again, I have the privilege of introducing my two colleagues here, Francis Garcia with Tennessee Voices and Aisha Robinzine with the Partners in Care program. So let's give them a round of applause for being here. So we'll start with you, Francis. Can you just tell us what Tennessee Voices is and exactly what do you do with the program?
So we are a mental health provider across the state of Tennessee. Our goal is to create a system of care to ensure that we protect our most vulnerable. We have a lot of partnerships with school districts. I happen to be a program manager and also a grant writer to help develop and write some of those programs.
Perfect. And then Aisha, what is the Partners in Care program?
So our Partners in Care program, we work at the precinct level. So our clinicians are embedded in all 8 precincts in Davidson County. And you have a master's level mental health clinician, and they are with a police officer. So, and they will basically answer the mental health calls for that as far as district. So there's 8 precincts, so there are counselors in each one. Basically, we operate from 6 a.m. as far as their A detail, 6 a.m. to 4, and then B detail, which is going to be 3 p.m. to 1 a.m. Basically, all the officers that our counselors ride with have gone through CIT training, so it's like it's a week-long program of where they're learning about, as far as mental health, what that looks like. Also de-escalation. We go over active listening with them because we all know, like, as police officers, you know, you're trained to, like, especially on patrol, they have a variety of calls. So it's more so teaching them those skills, especially when they come into interactions with those people who are having those mental health crises.
Perfect, thank you. So from a more macro scale, like when it comes to young people and mental health, like what are some of the trends and patterns you're seeing currently with our young people when it pertains to their mental health from a macro level?
Mm-hmm. So a lot of times our calls can range from instances where the youth are actually having, as far as like the suicidal ideations or experiencing some type of psychosis, but also just like we'll also answer calls where there is kind of like mood, as far as like mood dysregulation. So if there are instances where you get to the home, it's a DV, but also we notice that there may be some other aspects where they are not getting that like care or connection. Because what we thought when we first did the program, that we were going to be seeing more individuals that we already see and offering that support. But also within being in this program, we realized that there were a lot of gaps as far as people who don't know the resources are not linked to them. So that's kind of what we thought, especially with like the mood dysregulation. So if it's if it's more so getting into, and we could divert from going to juvenile for a domestic violence and like looking at as far as therapy, other options within the community, as far as definitely like partnering with our community resources like Tennessee Voices, then they definitely being able to divert from that.
And diverting from that, mitigating that lack of, I guess, education about the resources like Partners in Care, and then just increasing the collaboration with the community organizations.
Yes.
Do you want to add anything to that, Francis?
No, I think you covered it. But what I will add this, though, I think one of the things that I'm very passionate about is trying to create more of an intersection between institutions, right? Because the system can either make or break a child. All right, so how do we create more partnerships between the school districts, mental health providers, whether it's inpatient or outpatient services, and also merge that along with the police departments, so we can have individuals that are educated to be able to pass the resource on.
Perfect. And so I got a question for more along the lines of those of us who are could serve as resources to young people. What do you think that us as adults or us in spaces where we service resources for young people should be equipped with, beyond just the information. Like what are some of those things that we should have in order to be more resourceful to our young people that may be facing crisis in terms of mental health?
Definitely more training, especially with trauma-informed care and what that looks like. Because one of the biggest things that in our program, because I've been with the program since it was a baby and a pilot, that we've really looked at, especially when dealing with youth, is that you guys already have police officers in the schools. So when it comes to us going into certain places, being very aware of just like, hey, if I'm gonna go into a school, like setting the parameters for like this child needs to be actively trying to harm themselves or being like extremely physically aggressive towards like they cannot be kind of like maintained. And there's a threat to others because we also have resources outside of that to where if the child is willing and wanting to speak, especially since I am attached with an officer and they have to come with me, limiting that. So whether it's getting mobile crisis, because they have a kids team that gets dispatched to the community and them coming to talk with them, or getting our REACH unit to come out, which they're paired with a paramedic. And usually that's a more pleasant experience because if I don't have to have police presence in a situation where it's not needing that, then we'll definitely try at that.
Like who makes that determination whether police presence is required to maybe a mental health crisis or that our paramedics are responding?
Gotcha. So usually what will happen is we get dispatched through, of course, as far as police dispatch. So depending on how the call goes out, if it's definitely, usually if it's like extremely urgent, it'll be a code 3 and it's in the call text is like, hey, this child is aggressive. But if we are looking at that call text, it's code 2, code 1, where it's just like, hey, this child is experiencing suicidal ideation. So that gives our clinicians time to look at that and be like, okay, why can't mobile crisis go out? Or like, let's look at some of those things. We've also kind of, I know we've been partnering with our SROs recently just to give like that education and training as far as just like the different options as well, just so that we all are on the same page.
And just curious from both of your viewpoints and how you would define this, but we hear this a lot today, like trauma-informed approaches or practices. What is trauma-informed? What is being trauma-informed? What do those practices look like, especially for someone like me who just wants to be a resource to a young person?
So that's definitely going to be something as far as just understanding that we all experience trauma as far as differently, and also that active listening aspect. So a lot of times as adults, especially when I'm doing this kind of training, we always are just like, oh, listen, this is what it is, kind of like giving the information, but also allowing that time for that individual to speak, build that rapport, and also understand where it is that they're coming from. So it takes you more back to an active listening aspect. And then just being aware that, yes, trauma is different for each individual. I feel like that is something that's very big because like a lot of times when you hear trauma, you think of the worst thing possible, but that does not always have to be that case because what I feel is trauma and what someone else does is totally different. So that's where that active listening comes into play so that you're able to relate, understand, build rapport.
And also normalizing that it's okay to say you're not okay. That's what trauma informed actually does as well.
Any questions? I want to make this as engaging as possible as well. While informative, if you have questions, this would be a great time to pose some questions. We'll take some questions.
Okay. My question is for Partners in Care. I know that you guys are partnered with officers and you go out. I know I did a ride along, I think sometime last year, where I was able to observe that. But I know it was limited to maybe 1 or 2 officers. So my first question is, has that increased? And if not, is there going to be an increase of more individuals being partnered with officers to be able to go out when called?
Yes, so we have definitely, especially from like the conception of it, we had very limited. But what they've been doing is the officers have been going through as far as getting CIT trained. So they will go through that that training process. So we definitely have a lot more officers that are CRT trained at our precincts now. Especially because when they're with us, they're very limited. There are limitations on what they can do. And also they did not sign up to be clinicians 24/7. So especially to help that burnout, more so with officers, us clinicians, like we're here for it. But so they have a better rotation. So a lot of that also looks like on a supervisory level, when I go to precincts, seeing, especially after a rebid, seeing what officers they have, who's leaving, who's coming, who do I need to put in next for as far as CIT training, because we have them very regularly. We actually have a training coordinator who's embedded at the academy, and she's over getting all of that. And they start also doing, implementing it with the graduating classes that are coming out, so more officers are coming out CIT trained.
I had a question for both groups. I know you guys work with police officers and professionals, but do you work just like with the community? I know you said you wanted to make it more like help more mental health more normalized. How are you getting like your information out to the community to know about you, your health?
Gotcha. So on our end, it was kind of just like campaigns in the very beginning, just to letting everyone know that, hey, this is what's going on. This is as far as like our partnerships. And also because mental health can be very interesting and it can also pop up in different areas, it wasn't just showing up to where people are having mental health crisis where they, in the 10 code, like a 35 issue. Also, it could be in domestics, it could be in disorderlies. So like when you're seeing those calls and those trends, making sure that the clinician goes to those as well. When it comes to out in the community and doing community partnerships, like sometimes each precinct has what they call a COCO, and we'll try to get involved as far as in community events that they have. So like, I know like with back to school, they have like different backpack drives. We'll also be there as well with like resources just to let them know. But we're always looking for ways to be more involved. So if you guys have ideas, bring them on.
For us as TN Voices, we currently implement grants in several different counties, specifically aligning with the school districts. In Davidson County, we currently implement a grant that's going to focus on training school teachers on what they call youth mental health first aid, which is to prevent poor mental health outcomes in adolescents. Back in May, I wrote a program called Precious Sons, and we were able to partner with Big Picture High School, and we implemented that training session over a 3-week cycle. And then to commemorate that, each individual young man that went through the training received a certificate. That certificate came with the assistance of grant writing for additional education. It came along with resume building. And more importantly, what we were able to do was get them to invite any woman in their life that was making a difference in preparation for Mother's Day. We ordered Cracker Barrel. I had kids that wrote poetry, did art pieces, and so forth. So that grant currently is being implemented in Davidson County. And we're looking for principals that will bring us into the schools to allow that to take place and build those relationships. I think it's really important to give young people a voice, because I know what it felt like as a kid growing up in Miami, Florida, in a place called Pork and Bean Projects, called Liberty City. It was harsh. It was a harsh environment, and my environment dictated my actions. So if I can create an environment that would dictate your actions to be more positive and more fruitful, that's what I would like to do. I know what it feels like to be marginalized. I know what it feels like to be kicked out of 4 different schools and go to alternative school. I know what it feels like to be blackballed as a kid. I went to the military at 17 because of that, and it changed my life. But I lost a lot of friends along the way prior to leaving Miami, Florida. So, I'm excited to see good leaders in the room, SROs, good principals in the rooms, but it's also important to try to weed out those that are not so good for you young people. And that's why it's so important to have these kind of settings where you can provide that feedback.
I got a question. I felt like it's a national trend of men, American men in particular, men in domestic violence, men in domestic violence, and I start to see that same trend with my students at school, boys, just in the way they relate to girls. And then I started to see it, like my sister said, man, you see this trend of men killing their girlfriends, wives, baby mamas, those things. So I wonder how we can impact that on a school level to kind of work with some of the boys and girls about what to expect from men or partners or whatever, you know. But do y'all work with anything, or do you have any ideas to kind of address that, or how we should address that?
Yeah, that's what Precious Sons was about. Precious Sons, that was actually named after my godmother who raised me in the inner city. She was a correctional officer for over 35 years. She died December the 14th of last year. So I wrote the program on her behalf. And I reached out to different principals. I wanted to see who was interested in implementing this specifically with boys. And I reached out to Dr. Diaz, who's the principal of Big Picture. Subsequently, I was a guest speaker at their high school graduation a few months ago because of it. But the feedback that she provided was like, we need more for our young men, especially our young men of color. And I mean brown and black boys, because I'm a brown boy. I'm Dominican originally. I came to the United States when I was 10 years old, so I can dominate both of the languages the same. But she wanted to make sure that we had a focal point on the boys. She wanted to make sure that we were able to target them more. And one of the things that I did a lot of surveys with the kids, a lot of great feedback. There was a lack of male leadership in our community. And I'm sure that that's blanketed across this country. When you're looking at incarceration rates, when you're looking at the lack of, even in the public health sector, when you look at the public health sector that addresses some of these concerns and issues, is mainly populated by women. You know, so how do we invest more in our young people to get them to be in front of other young people, to provide guidance and a future? I think that's so important, but there is a lack thereof of male leadership in our community.
And for Partners in Care, I know that there's Partners in Care, and then there's the REACH program. And so the first question is about Partners in Care. And I know that usually when someone calls 911, if their young person is experiencing a mental health crisis of some sort, they usually have to go through mobile crisis first, and like there's this partnership. And maybe it would be good for you to explain how that looks if someone calls in and says, my child is having this experience, and what that looks like. I also like to know how the percentage looks, if you know numbers related to the youths who are in crisis that you have to kind of intervene with. And then if you could talk a little bit about the REACH program, if you know anything about it, that would be helpful. Thank you.
Okay. So when it comes to the first aspect as far as was how it works. So if a family member were to call into 911 and stating that their child was having, as far as a mental health crisis, usually a lot of times what will happen, especially because a lot of people in Nashville know mobile crisis and the number, so if you call into mobile crisis directly, they're going to ask you a couple of questions. If at all the child is showing any type of aggression or anything of that nature, they will, kind of do a three-way call with non-emergency to say what's going on, because when it comes to the safety as far as of the clinician, because the clinician is going out in their own personal vehicle, and if the child does not want to engage, or there's any type of aggressive behaviors where they have been hitting, punching, with family or younger siblings, they want that as far as just police presence, just in case we have to say that we're going to the hospital and the child wants to fight and do all those things. So as far as if there's that noted history. Now, just because a child has been aggressive in the past does not mean they are aggressive in the future. So I'm all about advocating as far as hey, my child has better insight today, I do not need police presence. I just need as far as a counselor. So that also means that mobile practice is available 24/7. If your child is agreeable, you could drive them to the facility and they could do an assessment there. What we really try to limit the police presence to is those high acuity calls, usually. And sometimes sometimes it's not always that, but we always like to be very upfront and honest, and as far as the presentation, as far as we do not have this available, so like a counselor will be coming, but they will be with police. You are not in trouble. They just have to literally be there to, just for the safety of the counselor. And a lot of times our clinicians 100% try to make that space, communicate with our officers, just about kind of how they understand that their presence can be a lot, and they do respect that as far as with the boundaries, as far as like they don't have to be like right there on my back, but like creating that space. So that's one of the, as far as like, those are usually the calls that we will respond to as far as the partners in care, because we're connected with police. So it's usually higher acuity. Our REACH program, they are partnered with EMS and fire. So they have their own, as far as car, it's like a Suburban, and they will answer mental health calls, lower level. So when it comes to that, especially since it all goes through dispatch, we've been working with dispatch a lot. So, and since REACH is a newer program, there are some like kinks and things that we are working out, but it's gotten a lot better to where if it's definitely something where they're stating that the child is not violent, anything of that nature, they'll usually try to see about getting the REACH car out to come out and assist. And yeah, so it's like lower level. Anytime that it would escalate further, then that's usually where we would come in. And when it comes to stats, unfortunately, I don't have stats when it comes directly to youth. I just know that when it comes to, within our program, we've had, how they track it is, usually when there's a use of force, police have to fill out what they call a 108 form. And within our program, we've had a 4% as far as like arrest rate. So it's definitely lower and less uses of force. A lot of our officers will let us talk for 2 hours if it means that they don't have to put hands on people. So they are very patient and they love that aspect because nobody's trying to, as far as escalate and do all of that. Because it also doesn't help as well. So a lot of times you'll see people who are just like, I was expecting a total different outcome, and then you guys came, and it was very interesting, it's very different. And a lot of that also goes to even looking at systems, especially like when it comes to helping individuals. So if we don't have to do, like finding other ways to help individuals, especially when it comes to, this is more so I guess adults, like if someone has a warrant, but it's not a warrant where it's like a shell arrest, then being able to work with getting mental health help first instead of directly going to jail. So those are like the routes that we're looking at as far as how do we differentiate between having to go to jail and then what are ways that we can help with getting them treatment first.
So MNPS has a program, Handle with Care. Dr. Brad may can relate to that. Is that, y'all have any connections with Handle with Care as far as
so when it comes to, so we don't use Handle with Care. All of our clinicians get trained on, oh man, it just slipped my mind. But it's a different form that we use at mobile crisis. However, when we are out in the field, we do not put any hands on any individuals, or we can't like utilize that.
So when I speak of Handle with Care, like it's a program in which like our school employees are notified when a student in the community has had a crisis incident, maybe overnight, maybe it was a domestic violence situation, in which we're, so when that student reports to school, like we know like, hey, John, mama, or dad had an incident in which dad went to jail because he put hands on mama. Or like say you might have an incident where maybe you have a student that has a trauma situation there, which they have a mental situation that maybe is related back to the Handle with Care program.
Gotcha, okay, sorry. Handle with Care in my neck of the woods is what we also use at inpatient hospitals for when someone gets aggressive and then we have to do therapeutic holds. And I was like, no, we don't do that.
We're a resource for Handle with Care, yeah. We do a lot of their outpatient services.
Yeah, Yeah, is there any way, I mean, because like I said, having a situation where, and I know you got help with things of that nature, but where like y'all can inform the schools like, hey, we get to come out and it was, and I know a lot of times with social workers, they probably are a little bit more in tune with that, where you make contact with the social worker that already has intel pertaining to that young person, maybe having a mental, health episode. I just didn't know if y'all have connections where we can kind of be put ahead to know like, hey, like this happened, maybe some triggers that may happen as the school day goes on.
Gotcha. I'm gonna look more into that because this is the first time of me hearing that, just to see as far as what that program looks like.
It's an MNPS thing.
Gotcha.
Perfect. Before we end this discussion, do any of y'all have any final comments or anything that you would like to say to the attendees?
I am one for, I love feedback. I feel like a program can't grow effectively without feedback, whether that be as far as what we need to do better or things that we did do good. So my take on all of this is if you ever do come into a situation where you have to encounter someone with our Reach or Partners in Care program, definitely giving us feedback on how that interaction was, what was good, what was positive, what was negative, what could have been done better. It's always something because I'm also overtraining for our clinicians and I always like to, as far as pour back into them, things that are actually effective and helpful. Because our clinicians also get a lot of training when it comes to that, but also there's never too much information that can be shared.
To the young people that are in the room, stay encouraged, stay motivated, stay positive. Just because you see every chair in this room is not filled does not mean that you're not special because you're in this room. This is the best room to be in on a Saturday right now, learning from adults that are trying to police you or trying to encourage you or motivate you. But stay encouraged, especially stay encouraged. Stay encouraged, stay positive, stay motivated, keep pursuing your goals, keep chasing your dreams, and hopefully somewhere along the line you'll run into an adult that will provide a foundation for you to continue to expedite your growth. Stay encouraged, stay motivated, love on yourself, and put yourself first. Put yourself first above trauma, above ACEs, which is adverse childhood experiences, things that you experience that may make you feel like you're not going to be successful. Stay encouraged.
Beautiful. All right, well, let's give it a round of applause for